Inflammatory bowel disease presents with highly variable clinical features depending on disease location, severity, and complications. Crohn's disease is typically more heterogeneous than ulcerative colitis. Abdominal pain is more prominent in Crohn's disease compared to ulcerative colitis. It may be colicky or persistent and is related to inflammation, abscess formation, Crohn obstruction. Ulcerative colitis commonly presents with urgency, rectal bleeding, diarrhea, mucus passage, and tenesmus. Symptoms often correlate with disease activity. Severe ulcerative colitis presents with fever and weight loss. Disease activity usually correlates with symptom severity. Crohn's disease often has a delayed diagnosis. About 25% of patients are diagnosed after more than 2 years due to subtle imaging and endoscopic findings. Ileal or ileocecal Crohn's disease commonly presents with small bowel obstruction. Patients develop colicky pain, vomiting, and right lower abdominal tenderness. Colonic Crohn's disease presents with diarrhea, abdominal pain, and systemic symptoms. Tenesmus is less common compared to ulcerative colitis. Perianal Crohn's disease may precede intestinal symptoms in about 24% of cases. The mean lead time can be around 4 years. Perianal Crohn's disease includes skin tags, fissures, ulcers, abscesses, and fistulas. These lesions may lead to chronic drainage and infection. Upper gastrointestinal Crohn's disease is rare and occurs in less than 2% of patients. It may cause dysphagia, chest pain, nausea, and weight loss. Fistulas in Crohn's disease occur due to transmural inflammation involving the full thickness of the bowel wall. This leads to abnormal connections between bowel loops and adjacent organs. Perianal fistulas occur in 15 to 35% of Crohn's disease patients. These are often low-lying and may cause chronic discharge and local infection. Internal fistulas include enterocolic, coloduodenal, colovesical, and rectovaginal types. These indicate severe penetrating disease behavior. Intra-abdominal abscess develops in about 25% of Crohn's disease patients over their lifetime. Glucocorticoids may mask fever and delay diagnosis. Strictures form due to chronic inflammation and fibrosis in Crohn's disease. Patients present with postprandial pain, bloating, and bowel obstruction symptoms. The string sign on imaging shows transient narrowing of the bowel lumen. It may reflect spasm or edema rather than fixed fibrotic stenosis. CT and MRI enterography are key imaging modalities for Crohn's disease evaluation. MRI is preferred because it avoids radiation and offers high diagnostic accuracy. Crohn's disease behavior is classified into inflammatory, stricturing, and penetrating phenotypes. Disease pattern depends on genetic and immune factors. Serologic markers include ASCA, anti-CBER1, anti-OMP-C, and PANCA. These help support disease classification, but are not diagnostic alone. Inflammatory bowel disease requires combined clinical, endoscopic, radiologic, and histologic evaluation. Early diagnosis helps prevent complications and improves outcomes.